have a concierge style membership practice. So there's not a lot of revenue opportunity in it. I don't think for me, it would be more cost than benefit.
For
Not
which, Ellie? For the Endopath or for this?
Yeah. For
Endopath. It's an expensive device.
Expensive.
Yeah. I have one in my office, and I also have kind of a concierge style practice, Ellie, similar. I used to have a much bigger one. I'm trying to pare it down, but I still have the Endopath, and I do find it useful. I kind of incorporate that into my assessments, of patients. It's kind of part of that bigger assessment. I don't charge separately for it, right? I just include it. So we can talk about that, the Endopath and the differences between that and the ultrasound. Now, Ellie, are you using the ultrasound a lot in your practice right now?
A lot's a relative term. I only have a membership of 210 patients.
Okay.
So it's pretty tiny. And I like it that way, because that way I only have to see patients 3 days a week. And,
absolutely.
And I stay sane.
Totally makes sense. And yet still 2 COVID patients. That's crazy, isn't it? Today. You broke up a little bit, Ellie.
I said, that's so strange, because I'm on Ethernet. I'm not even on Wi-Fi.
Did she break up for you guys, or is it just me?
No, for everyone.
Okay.
Yeah.
Okay.
Yeah.
So I said pretty much everybody over age 40 gets a baseline basal lab. And then anybody that's got yucky looking Cleveland Heart Labs, they also get a vasal lab. And often a coronary artery calcium score as well. And I do that one time, just the coronary artery calcium score kind of for baseline, but then I can track and monitor the vasal lab annually, or if it's really ugly, I'll even do 2 in a year in some patients. And, I tell them this is a way for us to objectively measure how much progress we're making. We can see your lipid numbers come down, but is it affecting your vessels? And this is a way that we can look at it and tell them yes or no. And almost always the answer is yes. And they like that vascular age number. The patients like that.
Yeah. Unless it's bad, and then they don't like it at all.
Yeah, right. And then it's motivating, right? Because I tell them, you can reverse that. And they love to see, oh my gosh, I got 5 years older, but my arteries got 2 years younger. So that's a net 7 gain,
Yeah. And are you seeing, Ellie, a lot of patients being able to reverse their vascular age and see better numbers on the vasal labs?
Yeah.
Good. So you're doing something right.
I mean, that's remarkable, really. So, I mean, that ought to be being
certainly not everybody, but like I had one the other day that had plaque the last time and no plaque this time. So
yeah.
And he was dancing around the office when he found that out, because he's not even 30, or he's close to 30.
Yeah.
And he's like,
So is his plaque calcified or the heterogeneous?
It was heterogeneous.
Yeah. And that's scary at 30, right?
It is. What I haven't seen, which I was expecting to see, is I haven't seen a lot of heterogeneous plaque become calcified. I was expecting to see a lot of that, and I really don't. I thought I would be maturing plaque and settling it down, and it stays heterogeneous for the most part.
That's interesting. I wonder why. Are you doing a whole?
I mean, I'm a Bale-Donine student, so we do the full.
Yep. Nice.
All those things. And I also do functional medicine, so I do a lot more than that. I check heavy metals and environmental toxicities and GI for dysbiosis, and we fix all that and look at their hormone levels and their vitamin levels and fix all that. So
are you
do a lot of I do a lot of sleep studies, way more sleep studies than I ever used to do.
There's an in-home
Watch Pat 1. we have it here.
That's the same one that makes Endopath correct, but there's actually a brand new FDA approved smartphone sleep apnea test where they download. You have to be ordered by a physician, but they can order it on their so you as a physician order it, then they download it onto their iPhone, stick the phone by their bed at night, and it listens to them breathe at night, and it can actually diagnose sleep apnea.
Interesting.
What's
No.
it called, Helen?
So it's called Resonea. Just as an FYI, I know that's not the purpose of this, but you might find that
Yeah, no,
handy.
that's interesting. Yeah.
So the app is called Drowsel, DR. So Resonea is the company, and the actual app is Drowsel with a Z.
So Ellie, are your I'm just curious. So those heterogeneous plaques that are not calcifying, are they just going away, or are they just staying?
Sometimes they stay, sometimes they shrink. Often they shrink. You know, they'll be like 1.6 or 1.8 millimeters, and then they'll be 1.4 or 1.2, but they'll stay heterogeneous.
It's interesting. Yeah.
Right.
But you know, my patients are geeky. They're highly educated and well motivated, and they like to see the data. They like to watch it and track it and monitor it. And that's one thing I would like to see on the VasoLab report is trends over time. You know,
Yeah, that would be
not
really useful.
not just on the CIMT measurement, but on the plaque measurement. Because they'll give you the trends over time of the CIMT, but not the measurement in the plaque.
And
And
I think
it also makes me a little crazy that it's statistically significant to 3 decimal places. Like, really? Is it really 3 decimal places significant?
That's funny. That's funny.
That's funny.
so. I think some of those for you, Dr. Campbell, will be answered in the future. That things we're working on developing now, that you'll have those tools.
Right. The other thing that I sort of would like to see is at what point do you make a diagnosis of plaque? Like for Bale and Donine, it's very clear. If you don't have plaque, then your primary prevention. If you do have plaque, your secondary prevention. But what's the number? Like, and is it evidence-based? Is it 1.3 millimeters? Is it 1.25 millimeters? Is it 1 millimeter? Is it 1.5 millimeters? And is it elevated CIMT with no plaque or plaque with a normal CIMT? Like, how do the experts decide what is actually plaque or what is actually risk? And then is that evidence-based?
From primary to secondary prevention, you mean?
Right.
That, yeah, I would love to know that.
And I would like to see that on the report somewhere. Like, you know, this, like with mammograms, I talk to my patients about the difference between the American College of Radiology versus the U.S. Preventive Task Force versus the European guidelines, right? So here's different experts' opinion and what they say we should be doing for you. So is there a difference of expert opinion for CIMT measurements and plaque measurements? And what are those?
Yeah, that's a really good point, Ellie. And I think, you know, we're using sort of standardized tables to determine the CIMT, kind of referring to that, but the plaque is a little bit more difficult in terms of getting that. Quick question, did Bale Donine, I mean, I know who they are, I've met them, great people, but I've not done their program. Do they say plaque? How do they determine plaque? With a carotid ultrasound?
Any marker will do. So if you have a dental x-ray and you have a calcified carotid artery seen on your dental x-ray, that counts. If you have a mammogram and you have atherosclerotic calcified blood vessels on your mammogram, that counts.
Got it. Okay.
If you do an abdominal aortic ultrasound and they comment that there's calcified plaque, that counts. Or a CIMT of, hey Joe, a CIMT of 1.3 is what they're using as convention, or an elevated CIMT, but I don't remember exactly if they say what percentage, like 75% for age or whatever. But it's kind of an either or thing.
Right. Oh, that makes sense.
So, shoot, my question just eluded me.
Or a coronary artery calcium score.
That's
So
what I was
if
going to
they,
ask you.
if they
Is there
have
a
anything
score
above
there?
a 0,
Anything above a 0?
plaque is plaque.
Calcified plaque is plaque.
Yeah.
Yeah.
And did you
she's
say it was
mentioning-
the plaque over 1.3 or the CIMT?
CIMT. No, sorry. The measurement of the plaque thickness in the carotids.
Yeah. Okay.
But I think that's by convention. I don't know if that's by evidence. So,
Ooh, I know this one. The
okay.
official definition of a plaque is 50% thicker than the IMT or 1.5 millimeters. So if your IMT was 0.6 and you had a bump that was 0.9, it's under a millimeter, and even that won't make my report. I had to pick an arbitrary number, and I just picked anything over a millimeter.
Can
If
you
you
say
look
that
at-
again, Joe?
50% thicker than the IMT. Any lesion or bump or inflammation, lump, foaming, whatever. 50% thicker than the IMT, or 1.5 millimeters is the hard floor, like the hard ceiling of that's definitely
in total, right, Joe? 1.5
So-
in total.
So I can think of a lot of weird cases, like the person who has their CIMT is 25% of their age. So it looks like they really don't have any plaque behind the drywall,
Yeah.
and yet they have a little bit thick spot of 0.7 millimeters. That could be a plaque in that person,
Yeah.
but you wouldn't call it. And
No.
you don't.
If it's under a millimeter, we'll put it on the back end, but I can't be putting everything on. So I have a floor of 1 millimeter. Some of my competitors will have 1.2 to get on the board, but I'll put it. So if you wanted to go back and check a patient, like did that come out of nowhere, you can do that, which is nice. But those are the two. So yeah, usually
So who says 1.5 and who says 50%? Is that American Cardiology Association or?
I've got it somewhere. It was a pretty
HA.
reputable. Yeah.
And I've been using that same stuff we're using too.
Oh,
Like,
good.
I can't put my fingers on this second.
Hey, Doc.
Because most of the Bale-Donine docs that I've talked with use 1.3, not 1.5.
Yeah, that might be a cardio risk thing, but I mean, that's conservative. That's fine. That works, right?
Right.
Yeah.
And then what about CIMT? If the CIMT for their age, if that's above a certain number, is that consistent with an atherosclerotic diagnosis?
The best we have is like 75th percentile and above. You should be on the board. There's good arguments for that. But over 75th percentile, yeah, they're on. Under, nobody has anything for like 65th, or you're either really bad or you're not. But it is important to remember the test is two parts: the plaque and the inflammation. The IMT inflammation, and usually they correlate. 80-90% of the time they're pretty similar-ish. But sometimes,
But I wouldn't, in my practice, not 80%, I don't think.
what would you call it?
I'd probably say 3/4, 60% maybe. I have to look and see, but it just seems like I have a lot of disparate ones.
And when they are disparate, how do you consider those? How do you consider that?
Either or. I do it at either or.
So they're pregnant either or.
Right. So if you have an elevated CIMT, like, 95th percentile for age, but you have no plaque, I still treat you like you have plaque. If you have a little bit of plaque, and I've been using 1.3, but your CIMT is low, I still treat you like you have plaque. So then that goes into the secondary prevention category instead of primary.
I mean, it makes sense to be conservative in those measures, right? Because you're not going to hurt anybody doing the secondary prevention versus primary. And
or you
having
might. I mean,
having a
that's
low
the thing
bar.
about functional medicine is we talk about, well, if I'm putting people on pioglitazone and a statin, what am I doing to their mitochondria over the long haul, right? And how long do I have to keep them on that? And can I do pioglitazone for a year or two and then take it away? And, what's my, right? Like, yes, I think you can hurt people with secondary prevention if
Yeah.
you're aggressive. So
they're recommending meds like that as part of their secondary prevention.
well, it's a full court press, right? So you do a 2-hour glucose tolerance test and you see if they have impaired fasting glucose, you might not be screening them for that had they not had plaque, because their A1C is very likely in the low 5s. It wouldn't bring it to your attention. I had a lady recently that had I forget what brought it to our attention, but her hemoglobin A1C was in the 4s, but she had 200 blood sugar on a glucose tolerance test.
Wow.
Yeah. So, clearly she was controlling her blood sugar, but didn't, just probably by diet, but
right. So she's a diet controlled diabetic.
Exactly. Yeah, but had
she
a
didn't
lot
like
of
that.
resistance.
She didn't like having a diagnosis. I'm like,
was she
I don't like giving
ketogenic?
it to you.
Ketogenic by any chance?
She was not.
I see that all the time in people that follow a ketogenic style diet where they have really terrible insulin resistance or terrible sensitivity, good resistance.
Right.
And
one of my patients challenged me, and she was a ketogenic diet and she flunked her glucose tolerance test, and she sent me an article that said ketogenic diet patients glucose tolerance testing is contraindicated because it'll give false positive readings.
I disagree.
How is it a false positive?
It's a positive reading. It's just that the ketogenic causes it, right?
Exactly. Yeah.
Exactly right, Martha. Yeah.
That's not.
She says it's because their bodies are so keto adapted that they're not able to tolerate glucose. Right, they're not able to tolerate.
Which is the definition of glucose resistance or insulin resistance, isn't it?
Yeah. That's a problem.
Yeah, I see that a lot. So
when I tried to get her to not eat ketogenic, she left my practice.
Yeah, well, diet is a religion for a lot of people. Yeah. Interesting. No, that's a little off topic, but I'd be happy to delve into that. That's kind of fun. Nice.
So Martha, you just have only had one clinic where you've done basal labs in your office so far?
Right. Yep. Just started. We had one in July, a few weeks ago anyway.
And how many patients were you able to collect for that?
I think we had 9. And we've got, a bunch of people signed up for the next one. So most of them were not unexpected findings, nothing terribly dramatic, except one mid 40-year-old woman who had a pretty bad score. I don't remember exactly what her 10 years younger, maybe 10 years older than she is chronologically. So without any obvious, it's going to open a whole door of assessment because it was a surprise.
Yeah. I will tell you, my experience has been when you see one side that's really hot compared to the other, there's almost always a dental source on that same side.
That's
so we start digging really deep for that.
And is there plaque and thickness or
explain? No, we see oh my God, that's the best type theory I've ever heard for that.
Is this a way to sell this to dentists? That's what I want to know.
Yeah, and I want a percentage.
That's,
you get it, right?
It's some type of unilateral inflammation, right? Which I agree, the dental makes the most sense for most people. I've seen it in other people that have had an inflammatory, something, breast cancer, other things like that. You see unilateral ones. So just that's something to build in, Joe, to see that. I think that's interesting. But the dental makes a lot of sense.
The patients with no inflammation but have plaque, I always thought that would be oral systemic cause, but like how do you pigeonhole that? Oh, that's interesting.
I mean, that's where the partnership with the dentist becomes so important. And it needs to be a biologically trained AOSH or AAPMD type dentist. I've had to send patients sometimes to 3 different dentists to get the answer. I said, well, how are your wisdom teeth? My wisdom teeth are fine. I don't have any. I took them out when I was a teenager. I'm like, well, what's going on in that socket where your wisdom teeth were? Oh, nothing. My dentist says I have a dark spot that's been there for 30 years. It's never changed.
Cavitations.
It's not a problem. And I'm like, well, get a second opinion. And then the second opinion dentist says, yeah, you have an asymptomatic dark spot. It's really not causing you any trouble. I don't think it's causing a problem. So, well, it's not causing a problem to your mouth, but it's causing a problem to your heart and your arteries. So
Yeah.
go see this
Yeah.
other dentist who found cavitations, and it turned into a big deal because she had them in all 4 wisdom teeth sockets.
Mm,
Wow.
that's tough.
Yeah.
So is there any, to go back to what we were talking about in the beginning, are there any, is there like head-to-head literature comparing? these
Yeah.
different,
There is some, Martha.
Yeah.
So there's some head-to-head literature on coronary calcium scoring and carotid ultrasounds. I'm just pulling one up here as we speak. It's like carotid plaque is more predictive of underlying silent coronary atherosclerosis prevalence and severity. And they've done these in different populations. So this one was asymptomatic type 2 diabetics. They've done it in people with fatty liver disease, where they've shown that the carotid ultrasound is better able to pick up very early atherosclerosis versus the coronary calcium. And
So
it
Helen,
picks
is
up that
that-
association with fatty liver, whereas the coronary calcium doesn't necessarily. Sorry, I cut you off.
No, is that by finding the plaque or the thickness in the CIMT, or is it
Both.
both?
Mhm. Yeah.
Yeah.
Yeah. And so there's a number of those kind of head-to-head studies. As
Okay.
far as the head-to-head studies with something like an Endopath, I'm going to have to dig into the literature a little bit more with that one. As you know, the Endopath is looking at kind of nitric oxide release, right? When
Right.
from a hyperemic response. So you cut off the blood supply, then you for 5 minutes let it flow back, and you see if the vessels will dilate. So you're looking really at endothelial function, which I think is clearly going to correlate with the IMT, but I haven't done a specific search on that one yet.
Yeah, and that's intuitively I agree. It certainly ought to correlate with the CIMT.
Mm-hmm. Mm-hmm.
Yeah, and
Yeah.
Don't search too hard on that. It's really more a question of, and I think that the issue is using the CIMT as opposed to just sending somebody to the local radiology place for their standard carotid Doppler. It's just going to look for the obstruction.
You're going to get a lot more with the CIMT, and you'll get a lot earlier. Yeah.
Yeah, exactly. It's the earlier.
Yeah.
Goes back to your prevention program, Ellie.
Right. Yeah, exactly.
Right. And I've never gotten a carotid ultrasound from the hospital that actually had objective measurement of, plaque of 1.7 millimeters or whatever. It just says mild, moderate, severe.
Exactly.
And it'll give me a flow study, right? How
Exactly.
much
The flow study. Yeah.
The Doppler. Mm-hmm.
the Doppler part of it. But
yeah.
That's not the question. I mean, that's the question. As a primary care family practice doc, I don't see a lot of those guys. I don't see a lot of people who need to go rushed off to the vascular surgeon. I think I've had 2 in 8 years, something like that.
Yeah.
So,
Mm-hmm.
most of them are, do you have plaque? And if you do, can we make it better?
Yeah. Yeah. So Helen,
If
what
you
do
have inflammation, can we, and that's with labs, we do that fire panel. And do you have inflammation and can we make it better?
Yeah.
Exactly.
So Helen, are you using a lot of the arterosil?
I do. I've recently, as you know, I've done a few talks for Calroy and arterosil, and I'm finding, it's really interesting. I had one patient who he loves to get, every quarter he does the massive amount of blood work and we follow everything. And I kind of, and I was measuring their phenotypic age. I was kind of plugging it into that pheno age calculator online. And I'm noticing he goes from, he drops 10 years and I'm thinking, what did we change, you know? And the only thing that was different is arteriosol was added, right? You know, so I'm starting to see improvements. And again, these are more, you know, anecdotal N of ones. We have
Yeah.
to do the full study, right? Completely. But I'm seeing like kidney function improve and, you know, blood pressure improving. And, you know, it's just really interesting. So I really want to do, you know, one of the things we're working with Basal Labs on is doing a really big research study to start tracking some of these outcomes using the carotid ultrasound, right? I mean, you've probably seen Christine Burke's kind of
exactly.
results, right? But you know, doing a sort of a much bigger, way more people study to see, and you know, we could use the Bale-Donine too, right? How does that reverse? What is it? The interventions that have the best effect at reversing it, right?
That would be Yep.
Yeah, I can't see a place. I've just started recommending arteriosol to everyone. I take it myself just because I can't see a negative from using it.
$100 a month, that's a negative.
Well, that's a big negative. But with your patients, maybe they can, right? If they're the concierge patients, which is
Right.
mine, right? So
Right.
they can afford it, which yes, that is a negative. It's expensive, but you know, can you cut away other supplements potentially, or other things to do that? I don't know. I don't get paid for arteriosol. I just do a talk for them every now and then. So I'm just
Right,
watching
right.
it.
Yeah, I
Yeah.
have not seen those changes yet. I'm just now about 3 months into recommending it, 3 or 4 months.
Uh-huh.
So I'm starting to see just starting to schedule my first follow-ups on
Follow-ups. Yeah, that'll be interesting to see. Yeah.
Yeah.
Some
Yeah.
good lab changes.
And Joe said he was surprised to see a subset of patients who get dramatically worse
Yeah.
on arteriosol.
Oh, that's
And,
interesting too.
And he said that what he thinks is happening is that they're maturing their plaque, that it was so soft, it didn't even show up. And now it's matured and more stable. But it was, he goes, I think we just missed it the first time around.
Right. That makes sense. It'd be interesting to follow that though. You know, are there patients who don't do well on it? I mean, that's something you want to know, but I don't think we know that yet. Yeah. Diabetics though, I find really helpful. Yeah.
Yeah, I've seen good numbers change. I'm anxious to see the, you know, the carotids change too.
And do you use 1 twice a day or 2 twice a day for your diabetics?
Yeah, 2 BID for the diabetics, but most of them end up taking 1 BID, honestly, mostly because of the cost, I think, like you said. Yeah. So.
That's exciting. Yeah.
Mm-hmm.
And what do you think about pulse dosing it? I know we're getting a little sidetracked off Basal Lab, but to me, it seems like if the job of these herbs, which is in this product, are to repair the glycocalyx, once you've got it repaired, I wouldn't think that you need to keep taking it every day. Like maybe you can take it 3 days a week, or maybe you can take it 2 weeks on and 2 weeks off, or maybe you can do it for 2 months and then off 2 months. You know what I mean? Like I'm trying to think about how can you cut back a little bit, in part because it's so expensive, but in part because of the physiology of what it's supposed to be doing. If I've already repaired my glycocalyx, can't I get by with less?
If you're sure you've removed all the contributors to the
that's
right?
exactly
that's
right.
Right, but those contributors happened for the 30 years before they ever saw us. And now
the glycocalyx, it's a lot like thinking of a leaky gut. It's such a dynamic sort of structure that it's constantly breaking down and building up. And so it's kind of like this balance, right? Are you building it up faster than you're breaking it down, or are you breaking it down faster than you're building it up? And as long as you're supplying the precursors for building it up, and that's, I think, where the arteriosol comes in. It's really supplying those precursors. You know, the same with a leaky gut. You know, can you ever say you've healed the leaky gut forever? No, because then they take an ibuprofen, or then they get, you know, and so it's constantly in flux. And same with the glycocalyx. It's a very, very dynamic structure. So if you wanted to pulse it, I mean, I have no evidence on
Right,
whether that
right.
would work or not, but I would not do like 2 weeks on, 2 weeks off. I would say like take a second day or something like that.
Right. Yeah, I'm not far enough along in my use of it to see, have I meaningfully changed the data? Right.
Yeah. Yeah, no, exactly.
Yeah.
Exactly. You know,
Yeah.
but if they continually if they still have high blood sugar or other things, you know, that have
Right.
caused it, you'll still be behind the 8 ball.
Right.
It's a pretty amazing product.
Yeah.
It's so funny. I'm seeing one of Mark Houston's patients for IV chelation. He has high metals, and his numbers got much better from the last time he saw Mark to this time, and he came to see me, and he wasn't on arterisol, and I was like, "Wait a minute." Dr. Houston said, I put everybody on arterisol that can afford it, and this guy can afford it. And so I'm like, why don't you check with him and make sure it's okay? Because he didn't put you on it. So I wonder if there was a reason. And are there any contraindications to arterisol other than
other than some
reaction to arterisol?
Exactly, other than some kind of allergy, I can't think of any contraindication. And cost, you know, like you said, but.
And another thing that I would sort of like to see on the VasoLab report is there a box for arterisol with a start date and a box for statins with a start date, right? So that it makes our tracking job easier.
So a box that you could fill in.
Right.
And
or the tech, when the tech is filling out, because I know our tech has started even asking about arterisol.
Interesting. Yeah, that makes sense. That's a good idea, Ellie. That's a really good idea.
And I think
as long as it's not written like something that.
I'm sorry, Kim, you broke up.
I think that can be something that we put on the new login page that we're working towards, that can be in your notes, that we can either in turn have printed out on the results, or it's just something that pops up when you get into that patient file in order to go over it with them. You know, like when you started meds, you recommended this, whatever it may be.
Right.
Yeah, to keep track of that. Yeah.
I think that's important.
Exactly.
Especially if we're going to have serial data on the report.
Yeah.
Yeah, you can say this is when you started arterisol, or this is when you started your statin. Yeah. Would you find it useful to also put, say, cholesterol numbers or things like that to start correlating that? You know, you've got sort of, this was your plaque, this was your cholesterol at this time, these were your readings for the IMT.
We talked about doing that.
Just so it's all together in a nice place, easy to see.
I don't know, because to me, cholesterol is not important, right? Cholesterol, NMR is important. What are your particle numbers, your ApoB?
That's what I mean, right? Yeah, like the fractionated numbers, and or whatever other thing. Do you put, you know, the MPO and the LPA too, or things like that, right?
Right. So how busy do you want your form to get? Are you going to put myeloperoxidase, LPPLA2, microalbumin, creatinine? Are you going to put all that stuff on the board? It's going to sort of could become an octopus pretty quickly.
Right.
I think it depends on how deep we want to dive into the data.
Right.
Yeah. Do you think, Ellie and Martha, too, that your patients would be open to participating if this was a research study, and that they could then also give permission to share their lab values, for example, and what their meds are and things like that? So, you know, so we can start tracking those kind of outcomes.
Some will be for sure, and some will adamantly refuse.
Okay. Yeah.
Yeah, I think I have plenty of people who'd be interested.
Yeah. Okay. Yeah. I mean, sorry, Kim.
I think it's an option, a checkbox on the.
Yeah, we give them an option to participate. And that way we could use the data, their data, right? It would be anonymized and all of that, of course, but
Yeah, I know my patients and they would be much more likely to participate if they got a discount on the test. Oh, you're going to give me $5 credit? Yeah, I'm doing it.
Okay, that's a good point. Okay.
Yeah.
Yeah,
Makes sense. Yeah.
it does. Yeah. Yep. I just would hesitate to put too much about meds or treatment on a form that's being tracked. And my reason for saying that is because there's such a varied approach, right, to different treatments. And if you put statins on there and someone isn't on chooses not to do that, and then has some untoward event, I don't know if there's just a little liability issue,
Yeah, so if it's a good,
to ignore it.
That's a good point.
good point. So in a research study, no one is allowed to have access to that data.
Oh, if it's in the research, that's fine.
Yeah.
But we were talking about putting it
Oh,
on the
but
form.
I see what you mean. Yeah. Okay, that makes sense. Yeah.
So not having it on the form, but maybe where you could see it. Would that?
That would that I think would be a better idea. I just am afraid.
Okay.
It's probably a long shot, but
It's a good point, though.
Better to be something hard.
Yeah, I agree. Makes sense. Cool. So are we answering your questions, Martha?
oh, absolutely, yeah.
I'm just looking, how are you offering this? Why this test as opposed to another one? I mean, I think that is, it's easier, cost might be lower. I find that the picture's always worth 1,000 words, right? So seeing pictures can be very motivating for patients.
Yeah, I agree. As I said, really the discussion with Joe is what prompted this, how can we help other people learn about this.
Exactly.
And why would you, what are you going to say to the community cardiologist who wants to know why you're doing this test when, they would choose something different? But I think
I mean, it doesn't, exactly. It doesn't have to be an instead of, for example, I'll use Endopath as a screening on everybody because I have it in the office and it's easy and it can do it anytime they're here. But then I'll send, if I do see something, I'll send them for further testing. Right. So I will send them for a carotid ultrasound or a, coronary calcium, depending on, or both to Ellie's point. So I don't think it has to necessarily be in place of others, and especially if you do see a really awful result, you may want to
That's an interesting question. Is there a plaque number that would trigger an automatic regular Doppler study? I mean, I think we can look at it visually and say, oh, that one looks ugly, so off you go.
Yeah.
Is that data based, or is that it looks ugly?
Well, we were talking like 50%, but it's that would probably be your call in terms of, okay, I'm going to follow up on this with another study. And, doing the coronary calcium one time too, yes, there are head-to-head studies that show that this is better for an earlier, earlier identification of atherosclerosis than the coronary calcium score. But when you see that, right, when you say, if I see a dysfunctional Endopath or really bad IMT, carotid ultrasound, you kind of want to know what the extent of the damage is in other places. So, then sending for a coronary score to see where you're at makes sense.
Yeah, for sure. Yep. Good.
I wanted to ask a question, if I could, about the on the back of page 1. Pull up a report and see if I can find one here.
Do you want to share your screen?
You find somebody who's had a vaso lab recently. Let's see.
So Martha, where are you located?
I'm in Northern Virginia.
You're in
Please.
Northern Virginia. Okay.
Yeah.
Yeah, I thought so.
Where are you?
I'm in San Jose right now. Yeah, California.
Yeah.
Driving my son off to college next week.
Uh,
Kim and I have been talking about that. It's so sad.
is it your first kid to college?
My second, my last, my baby. So the
It's
first
when the
one was
babies go
hard,
up
but I
and
still
down.
had the baby at home, right? So,
Right.
Yeah.
Yeah. When we
It's those
became empty
babies going
nesters, we
off.
got a dog.
yeah, well, we have a dog.
We couldn't stand it.
Just leave it alone.
I'd had a dog for 25 years, and then after Trapper died, we never replaced him. And I had kids all the time, and
Right.
but then when the house was empty, I looked at Jim. I'm like, we need a
We're getting a
dog.
dog.
Yeah.
They're 100 pounds apiece now. They were puppies when we first adopted them.
Wow.
All right, how do I share my screen? Is it present now?
There should, yeah.
Yes.
That's the
Present
one.
now. Okay.
That's funny.
Where's your son going to school?
He's going up to University of Victoria. So I'm Canadian. So I have one son in Vancouver at UBC, and this one will be at UVic.
Nice.
Yeah.
Right.
So a ways away. Okay, here we go.
You see my screen?
Yeah.
Okay. So you say 50% block, but here on this report, it says 49% is normal. So you're going to send somebody with a 50% CCA block? 1% higher than the carotid
Yeah,
stenosis?
that's a judgment call. Yeah. What would you do in this case, Ellie?
Anybody that, for me, I say to them, and I don't have these very often, but if you have a 50% stenosis, I would say that's mild disease. And that means we need to be very aggressive with you. If it's above 70%, they go to vascular surgery right away.
Mm-hmm.
And almost all of those come back to me as it really wasn't 70%. It was only 62%. They're still in the mild disease category. We're just going to watch them, which is fine.
Yeah.
And they got a vascular surgeon. The liability's on them, and I'm going to help reverse that where the vascular surgeon won't.
Right.
But
Totally.
so I don't do much with the 50%ers other than everything else that I would do. And this one's a little unusual. This is a 2018 test. When I first started doing basal labs, I did triple screening on everybody.
Mm-hmm.
I did their carotids, their aorta, and their ankle brachial index.
Mm-hmm.
And I kind of stopped doing that because I wasn't getting enough positives. It felt like I was spending too much of their money and not finding it. Today, I only do the carotid, and if that's more than the 75th percentile or more than 10 or so years older than their age, then I'll probably catch them on the next time and do a AAA screen and a
Right.
and a lower
ABI.
screen,
Mm-hmm.
LEAD. Yeah. So I just was wondering, you said 50% you get a consult. I'm like, whoa, 1% more.
No, we were saying getting the Dopplers, not necessarily a vascular consult.
I see.
Yeah.
But this report,
Mm-hmm. Yeah.
I mean, aren't these numbers Doppler readings? Isn't that what those are?
Yep.
Okay. So like Jenny here, I said, 1.2, 1.12, that does not meet my criteria for atherosclerosis, but it's heading in that direction. So let's be a little more aggressive about your blood sugar and your lipids, but she's not really in my secondary prevention category. So she's not getting the full court press of the slew of labs that of meds that they would go on were they to be secondary prevention. She's not going to get aspirin. She's not going to get statin. She's not going to get 2-hour glucose tolerance test probably. So.
Got it. That makes sense.
All right, that's all.
No, that's great.
I will unshare if I can come back to this and stop presenting. All right.
So does anyone have anything else?
No, it was great. Thank you.
I looked at your list of pre-prepared questions. I think we got them all.
Did we cover them all?
Yeah, I think so. Yeah.
Good.
Yeah. But I do think it'd be, useful to have something like that available for people who were considering incorporating this,
Right.
Yeah.
Yeah. I mean, I really like the serial monitoring. That's the thing that I like the best. To me, one report's not that helpful. I mean, it's some helpful, but it's the trends over time that let you know, are you doing enough? Are you doing the right things? And if you're not, what have you missed? What on your tree have you not thought about? Is there some other contributor? And to me, 9 out of 10 times that contributor is dental, oral, systemic, gingivitis, dental, or oral, in that I also consider nitric oxide and sleep apnea as oral conditions. So.
Oh yeah, no, the sleep apnea is missed so often.
It is, isn't it?
Yeah, absolutely. Yeah, the dental, anytime there's some barrier break and the microbes from the mouth get into systemic circulation, it's going to cause, be associated with atherosclerosis. And so it's a big, big deal. Yeah, we're finding all these organisms in these plaques, right?
Well, it's a huge part of Bredeson's work too, right?
Mm-hmm.
Yeah,
absolutely. Yeah.
And Chip Watkins really pushed the oral systemic thing on Dale. So Dale's much more attuned to it now. He sort of skirted through it, but now it's like a real focus of his. So I'm glad to see that.
Mm-hmm. Yeah, no, that's good.
And just I'll put a plug in. I'm on the board of directors of the American Academy of Oral Systemic Health, AOSH.
Oh, cool. Okay.
750 dentists and 5 doctors. And I took Brad Bale's place on the board of directors. He asked me to take over for him after he got too busy and didn't want to do it anymore. And we have our annual conference in September in Atlanta. And it's a co-conference. It's called Collaboration Cures. And it's co-conferencing with AAPMD. And at least a third of the lectures are on airway. So sleep apnea from the dental perspective and myofunctional disorders that result in sleep disturbances. And there's lectures for physical therapists, for dentists, for doctors, a whole bunch of stuff on oral microbiome. So come to Atlanta and come to our conference. It'll be great. I think we have 800 people registered already. So.
Oh, wow.
Yeah.
And that's September, so that's coming up pretty quickly.
Yep.
Nice.
Can you send the link for that, Ellie?
I can.
Yeah.
How do you want me to send it? You just want me to?
Can you put it in the chat?
Yes.
So if you'll do that, what I will do to each one of y'all is I will also send this into a doc. It'll download on my Google Drive, and then I will share it with you guys so y'all have permissions to it. And then we're going to do a little write-up on it as well.
Okay. Thank you.
That's great, Kim. Thanks.
Appreciate it.
Nice.
There's a separate one for.
So it's still going ahead even with the Delta surge?
We are for now.
Yeah. I just was Jeff's PLMI and is supposed to be in October. And I was just talking to Annette. They may end up going all virtual as well, rather than live.
Yeah.
Didn't Bell go completely virtual again? For the one coming up for them in November?
Did they?
That
I don't know. Yeah.
Which one was that?
Yeah.
The Bale Doneen one?
Mm-hmm. I think they went virtual because I think they were planning on doing live, but for some reason it seems like I saw something that they're going virtual.
Yeah, I hadn't heard. I got it. Perfect, Ellie.
Thank
you. Welcome.
Yeah, I think that's a really missed area of health. 100% agree with you. Yeah.
Well, perfect. Well, I appreciate y'all's time.
Thank you.
Welcome. Thank you. Thanks for hosting.
Oh, no problem. And we will probably do a few more of these. I would love to get more questions and have to be able to do things like this, and maybe we have a question and answer section on the new web portal that people can actually go and look at and see.
Yeah.
So that's kind of the goal of it.
Okay. All right, ladies. Thank you for your time and attention. It's nice to see you all.
Appreciate it.
Have a good evening.
Okay.
Helen, let me
Bye-bye.
know if if you want to talk any more about the research. I'm sure that I have patients. That'd be very interesting to me.
Yeah, absolutely. Thank you, Martha. As you know,
Yeah.
that's kind of what I like to do. You know, we all do
Exactly.
these things, and
I know, but we might
we
as well.
don't really track outcomes very well.
No, we
You
don't.
know, we're so anecdotal, right? And which is great. And as a clinician, you have to make decisions, at that point in time for that person. So you're going to make decisions with incomplete data, but we should track that. And so the next time we make that decision, we have more data around it.
Right, but particularly when you've got something as potentially or probably as powerful as arteriocel. I mean,
Yeah, no,
so
exactly.
we're measuring this and measuring the labs, but like you said, think of if we could track like the GFR and the, whatever else.
Exactly. All of those other, yes,
And
exactly.
I'm personally not likely to be using statins and
Yeah, I
the
mean, I
medicines.
think that comes from Baldonine. I
Yeah,
think that's
yeah,
their,
absolutely.
definitely secondary prevention. I
Yep.
hadn't realized that they're that aggressive, even with, the various hint of plaque. Yes, if someone's had an MI as secondary prevention, maybe but
Yeah.
it's interesting. It's interesting. I have not gone through. Have you gone through their course?
No, I haven't.
Yeah, no,
So
I
I don't
haven't.
know, but I would hope that they would address something like, using high dose berberine first or something. But
Yeah,
maybe not.
yeah,
Who
exactly.
knows?
Exactly.
Who knows? Yeah, I see.
Yeah, no, and I'm reading about statins, and it turns out that, there's a lot of conflicting data on statins and dementia risk, right?
Huge.
Some studies say it helps, sometimes say it makes it worse. Turns out, I just saw one yesterday that shows it's the difference between lipophilic versus hydrophilic statins. So it turns out that the lipophilic statins have a much higher risk for dementia, but the hydrophilic ones do not, which is very interesting.
That is interesting.
Yeah, so somehow, the lipophilic ones may get into the brain better and, have an effect on cholesterol in the brain, which puts you at higher risk. So anyway, if you Google it, there's a nice list of which ones are lipophilic and which ones are hydrophilic. But
For sure.
Crestor is hydrophilic, just as an FYI. I had to check that for a couple of patients. It's hard when their cardiologist puts them on all these drugs, and it's hard to take them all off of them.
It is, isn't it? Yeah. There's the
Yeah.
degree to which you can do that.
You don't want to necessarily, and then if something did happen, yeah, it's interesting. But this is
Although
great.
The vast majority of the people who access us still at this point don't want those drugs, so that does make it easier if you document it well. So
you just need to document it exactly.
Yeah.
Exactly. Yeah.
Yeah. Well, this was great. Thank you. Good luck with your son.
Well, thank you. I appreciate that.
Yeah, mine just got married this year, and it's
oh wow. How does that happen? I know. But nice to talk with you, Martha.
Nice to talk to you. Take care. Bye.
Bye-bye.